Hey coders, let's talk about advanced care planning, or ACP. Let's talk about what is advanced care planning, what are the documentation requirements, and what are the billing codes used. Advanced care planning is a voluntary face-to-face discussion between the patient's provider, this could be a physician or other qualified healthcare professional such as a nurse practitioner, and the patient, their family, caregiver, or surrogate, and it is an opportunity for them to discuss the patient's healthcare wishes if they are unable to make those decisions for themselves. So what are some examples of this? It could be do not resuscitate orders, determining a healthcare proxy or power of attorney, a living will, medical orders for life-sustaining treatment. This could be, does a patient want a feeding tube? Do they want to be on life support? Those type healthcare wishes. Advanced care planning can be performed with or without forms being completed. What are the documentation requirements? It's important to document that the visit was voluntary, an explanation of advance directives, who was present, was it just the patient, was a family member there or a caregiver, the amount of time spent discussing advanced care planning. Time is needed to bill advanced care planning. Is there any changes to the patient's healthcare status? That would need to be documented as well. And most importantly, what are the patient's healthcare wishes if they can't make decisions for themselves? There is not a specific diagnosis that is required for billing advanced care planning. However, Medicare does state to report the condition discussed with the patient. For example, I work for a nephrology practice, and when patients have end-stage renal disease and they're in the dialysis units, often they'll speak with their provider about advanced care planning, and it would be appropriate in those cases to use the ESRD diagnosis on the advanced care planning charges. So let's take a look at the CPT codes used to bill advanced care planning. We have 99497. And there is a description included on this slide, which includes the explanation and discussion of advanced care planning, whether or not forms are completed by the physician or other qualified healthcare professional, and there's a time component here. If there is additional time used, there is an add-on code that can be used in addition to 99497 for advanced care planning. Let's take a look at the times required for advanced care planning. So time for advanced care planning follows the CPT midpoint rule. And Medicare has this lovely little chart that shows you exactly how much time is needed to bill for advanced care planning codes. So if it's less than 15 minutes, then it's just included in the E&M, and you can't bill one of these advanced care planning CPT codes. If it's between 16 and 45 minutes, you'll bill 99497, 1 unit. If there's additional time beyond 46 minutes, then 99497 can also be billed with 99498. And if there's additional time, as you can see on this chart, there are additional units that can be used. So here's some facts about advanced care planning. It can be for all patients. There's not a limitation on which patients can receive advanced care planning. There's no limit to the number of times advanced care planning can be reported. However, if it's reported more than once, it's important to document what's changed. Let's just say a patient is seen, they have advanced care planning, and at that point in time, they want to be fully coded. However, let's just say their health status deteriorates and the patient decides that they no longer want to be full code. They want to sign a do not resuscitate order. In that case, that would need to be included in the documentation to support the billing of another advanced care planning service. There's no place of service limitations. It can be done in the office, the hospital. As I mentioned before, I work for a nephrology practice, so patients have advanced care planning services in the dialysis unit. It can be billed with additional services. A modifier 25 would be needed. I recommend that you check your Medicare's local coverage determination. For example, my local MAC is the Palmetto GBA. The Palmetto GBA has specific rules for advanced care planning, and one of them is that they state if you're billing an E&M service and you're also billing advanced care planning, they want modifier 25 on both services. This may not be true for all MACs, this may not be true for all payers, so you may have to do some research on that, especially if you're receiving denials. Another thing about advanced care planning is you can't double count time. Let's just say you have a patient, they come into the office and an evaluation and management service is performed. And advanced care planning is also done as well. If the E&M is based on time and you're also billing advanced care planning, you can't double count the time. It has to be very clear that the time is distinct between the two services. I highly recommend that providers document something to the effect of spent 40 minutes with patient performing physical exam, counseling on CKD, coordinating with cardiologist, and documenting in the medical record. Spent an additional 17 minutes performing advanced care planning services and detailing what was included in that discussion. So I think it's very important to make sure the documentation is clear, that there's no double dipping with time. So that was a brief overview of advanced care planning. I hope this has been helpful to you. If you have any questions, please leave them in the comments below. I'm happy to answer them. Stay sharp, coders.